A very good morning to you. Thanks for joining us for our event today, focused on the important topic of the ever-growing NHS backlog, delivered to you by National Health Executive. Welcome to new faces here for the first time, and hello to those of you who join us every 2 months for these conferences, packed full of content. The National Health Executive is always keen to deliver content which inspires innovation on the platform long after the event has finished. Today will be packed with opportunities to network and acquire industry knowledge and best practices from other NHS professionals. So I hope you're looking forward to what we've got in store. We must thank the industry leaders and experts who have taken time out to join us to share their high quality insights. Due to the standard of content that will be shared on our NHE 365 platform, it's worth pointing out that all content is CPD certified. So for every hour of content you watch live, you'll earn 1 CPD point. To receive your certificate, please email the NHE team at marketing@cognitivepublishing.com. That's marketing@cognitivepublishing.com, and they'll provide you with a copy. Our networking opportunities can be accessed via the speed networking function, and I really do encourage you to collaborate with your colleagues as another valuable source of education. This all plays a part in the community we're growing to extend the reach of knowledge and connections shared today, which can be accessed at any time to fit in with your busy schedules. Also on the NHE 365 platform, access to a wealth of resources on our on-demand content section alongside the digital marketplace, providing expertise for you and your teams to digest at your leisure. Finally, do feel free to share your thoughts and experiences today across social media using the hashtag NHE365. So there's a bit of background to start us off. Let's move to the main focus of today. At the start of the pandemic, the number of people on the NHS waiting list for consultant-led care dropped from 4.2 million to 3.95 million, a fall that hadn't been seen for 7 years. From July 2020, that figure began to rapidly increase and has been growing at an incredible rate for the past 2 years, leaving us with a record 7 million people currently waiting for treatment. This figure includes 2.87 million patients waiting for more than 18 weeks and more than 400,000 patients waiting for more than a year. According to recent BBC analysis, there are fewer operations happening than there were before the pandemic. Hospital teams are carrying out 12% fewer operations compared to pre-pandemic figures, with surgeons describing the situation as frustrating as theatres remained empty due to a lack of staff and hospital beds. NHS England say they want to increase the number of patients seen and treated by increasing their capacity through growing and supporting the workforce, using digital technologies, and adapting the UK's infection and prevention measures. The NHS has also said it will be prioritising treatment to more vulnerable patients by increasing the number of cancer treatment referrals, managing wait times by targeting patients who are in need of greater support, and ensuring it's reflected with their clinical needs. In this virtual conference, we'll be discussing how NHS professionals can reduce backlog using recruitment, digital technology, infrastructure, and patient flow. So with that, I'd like to introduce you to our opening keynote speaker, Erika Denton, Medical Director for Norfolk and Norwich University Hospital. As National Advisor on Imaging to NHS Improvement and NHS England, Erika provided advice from 2016 to 2020. She chaired the National Imaging Optimisation and Productivity Delivery Board and led work to improve imaging services across England, as well as worked with NHS Digital on implementation of artificial intelligence in imaging. Erika will be speaking to us about the NHS Long Term Plan, the Professor Sir Mike Richards' report, and the NHS's priorities and guidance for operations, as well as the relief of backlog pressures. Erika, I'd like to give you a very warm welcome to our virtual stage.
Thank you very much, Helen, and good morning, everybody. It's a pleasure to be with you and to talk about diagnostic services and the backlog. Can I have my next slide, please? So as Helen has already described, I'm going to be talking to you with a bit of background, the Mike Richards review and the current key performance indicators for diagnostics, and then a little about national diagnostic initiatives and about what we're doing locally to address the backlog for diagnostics, which is the largest I think any of us have ever seen or even could have imagined. Next slide, please. So back in 2019, in those heady days before we knew of COVID, the NHS on diagnostics. It discussed the traditional model of outpatients being outdated and unsustainable, and a requirement for us really to transform services and invest in faster modern diagnostics with appropriate resource. Next slide, please. So in 2020, Mike Richards reported on the need for diagnostic service change. And I've included in my slides, which should be available to you all the links to the relevant documents for further reading. So Mike's report, which I was involved in supporting and helping him with, describes a need for the physical separation of acute and elective diagnostic services to increase efficiency. And that's an evidence-based requirement. We know that for populations to have access to effective diagnostics, it is much better for them to have acute service diagnostics next to them in the acute hospitals with separate facilities for elective outpatient diagnostics. Those don't necessarily need to be off-site, but separated in terms of how they function. It improves flow for the hospital, so inpatients get more rapid diagnostic services, and outpatient access is also improved. This improves particularly delays to CT and ultrasound access for inpatients. There was a requirement described by Mike for same-day scanning for CT and MR for inpatients, which we've been promoting for many decades now, but we know many hospitals don't have the resources and the capacity to undertake. And this was the first document that begins to describe community diagnostic hubs or community diagnostic centres, which I'll talk more about in the coming minutes. Diagnostic services should be organised as far as possible so patients only have to attend once. So those of us who are cancer service providers, so I'm a breast and gynecology radiologist in my breast practice, one-stop services underpin everything we do. And we are working very, very hard nationally to promote those kind of services for all pathways. There's also a in Mike's report around community phlebotomy. In many rural and remote areas, my own included, and I'll show you some maps in a little while, phlebotomy services are particularly challenging, with patients having to take whole days off work just to get a blood test. Next slide, please. So what are the current key performance indicators and how do we look at diagnostics in the round nationally? So we have 15 diagnostic tests collected in what's called DMO1, which is a data set collected from all diagnostic providers on a monthly basis. And you can see them down the left-hand side of the slide. We measure for each test patients waiting longer than 6 weeks, the total waiting list, so the total number of patients waiting, and median waiting times with total activity also collected. So you can compare your activity with your number waiting and calculate clearance times from the DMO1 dataset. In addition, we're now collecting CDC, so Community Diagnostic Centre, additional activity as a separate KPI and data. And we're also collecting information on elective recovery against the 1920 outturn. So for those of us who've been very focused on recovery after the pandemic, this is a key performance indicator with an objective for us to be performing at 120% of the 1920 outturn data. That's quite a big ask, and many, many hospitals are really struggling with this. And it's the same for all elective work, not just diagnostics. Next slide, please. So the latest data, and this is data from back in November at the end of last year, and I've highlighted in red the key figures. So the DMO1 data set that I've just described to you shows that at the end of November, there were close to 500,000 patients waiting 6 weeks or more for one of those tests to be undertaken. But there were also almost 1.6 million patients waiting in total. And that's gone up progressively over the period of the pandemic. So 1.6 million. And to put that into context, in every month, the number of tests undertaken is over 2 million. So in November, in the NHS in England, over 2 million diagnostic tests were undertaken. So you can then calculate the gap in terms of service provision and the number of people waiting. It's quite a difficult ask to ask the NHS to clear almost a month's worth of work to get on top of those waits. Next slide, please. So what about the operational guidance? So the 2023-24 guidance, and this guidance is always, amusingly, for those of us who are executive directors, published on or around Christmas Eve. So because that fell on a Saturday this year, this delight arrived for all of us as our Christmas reading on the 23rd of December. This describes some very significant things for diagnostic services. The operational guidance asks us to maximise the rollout of additional capacity, delivering the plans for community diagnostic centres and ensuring that we get those locations in form and upgraded to actually deliver the objectives set for us in the previous year. A minimum requirement of a 10% improvement in pathology and imaging network productivity through digital diagnostic investment with optimised rates for tests. So that's an optimised turnaround time. Improving GP direct access to testing with funding critically to support pathology and imaging networks and the rollout of community diagnostic centres. And that capital funding is 2.3 billion. So it's a very big chunk of cash that's coming allocated to diagnostic service transformation to implement the community diagnostic centres, endoscopy, imaging equipment, and digital diagnostics. Next slide, please. So what does all of this look like on the ground? So this is a slightly complicated slide that I'll talk you through. So the donut on the left shows the breakdown of costs for imaging departments. So it's a very hefty pay bill. So if you look at this, you can see the pay costs of substantive staff is in grey, non-substantive or locum staff. This is NHS in England back in 2017, 2018. We don't have this data any more recently. And you can see then that the blue section of the donut is capital, so that's equipment. You can also see the vacancy rate back when we last measured it most effectively was 12.5% for consultants, and in the non-medical vacancy rate of 15%. So that's radiographers and other non-medical staff. Across England, we report 39 million imaging tests a year, and 182 million in that year, 17-18, was spent in addition on outsourced and insourced capacity. So that's either paying people above their NHS contract on waiting list initiative work or outsourcing to other providers, teleradiology particularly. And the other aspect I wanted to highlight to you was the huge variation in how staff are used across imaging departments. And this is the proportion of plain films along the bottom reported by non-consultant staff, so radiographer reporting. And you can see that massive variation from none. So some departments have no radiographers doing extended practice through to almost all plain films being reported. And this sort of sets the scene as to how you can use your workforce differently, but also some of the challenges with massive vacancy rates. Next slide, please. So what about the National Community Diagnostic Centre programme? So this publication is really significant, and it gives guidance for how we plan, design and implement community diagnostic centres. So for any of you who want further reading, this describes the service specification and what's required locally to actually deliver CDCs. There are 6 primary aims described, and these are absolutely what we'd all sign up to: improving population health, increasing capacity, improving productivity, efficiency, reducing health inequalities, improving patient experience very significantly, and also supporting integration of primary, community and secondary care. And then there are some cross-cutting aims. Importantly, we're now seeing a contribution to net zero ambitions being highlighted in almost all programmes nationally. Really significant that we absolutely embrace that. We work really hard around our net zero ambitions, difficult for hospitals, big plastics users, big electricity users, etc. There's a requirement for us to share learning across systems, so not to be responsible only for our little silos, and also to make every contact count, support health promotion, quality improvement, research, innovation, and staff development. There's a broad range of elective diagnostics included in the CDCs, with 3 models described in this document: the standard, a large, or a hub and spoke model. And these will be rolled out nationally according to local need, because everybody's prior services are different and everybody's geography is different. The year 1 of this programme is focused on setting things up with early adopters and everyone else learning from those early adopter sites. GP direct access will be supported in all CDCs, not just a selection. Next slide, please. So I'm not going to go through in massive detail. This is the plan on a page for diagnostics transformation. And this is what we're doing around national diagnostics workforce. So the CDCs will require us to have a workforce that is working in different environments. And in many geographies, that will be nearer to patients. So for some workforces, such as radiographers, that might be splitting a workforce between an acute and then a rural and remote site. So we will need to look at how we use the workforce to best effect. Networks enable us to use our workforce massively better. It enables us to, for instance, use the skills of a radiologist who reports perhaps high-end complex MRI across a wider region. It gives patients equitable access to that expertise. We will need to digitally mature some areas in the country to enable all of these things to happen. And there is a large amount of equipment needed for the new CDCs. Next slide, please. So the workforce delivery principles are described here. We know we have to recruit and grow a bigger workforce, but we also need to make sure we retain the workforce we train. And many aspects of the CDC programme will be looking at how we can extend the roles of existing workforce and also expand a new workforce who perhaps. So for instance, in Norfolk and Waveney, we're looking at whether we could train people to do every aspect of an annual diabetic health check. Instead of having somebody go to have a blood taken and then a foot check, an eye check, etc., we'd be doing all of those things with one person. That's a new kind of workforce, and it involves agility locally in terms of training and also an acknowledgement of crossing some previous professional boundaries. We will need skill mix across the workforce. We do need to ensure we have career development for our staff and a digitally enabled workforce who work across systems. That will require significant leadership. And this maps out how we're working with NHS and Health Education England to develop the workforce of the future. So imaging networks have formed across the country. there are some really significant benefits, and the 12 main ones described by the more mature networks are described in this slide. The most significant are that you can actually sustain a resilient service by networking. It allows staffing consistency and flexibility and staff retention. We know that the reporting workforce in imaging delivers the best possible care for patients with more flexible working, home reporting workstations, the ability to report in an agile way, as well as having the opportunity to be part of a team with a base, usually in an acute hospital. Equal access for all patients, irrespective of geography, is fundamental, with sharing of capacity and management capabilities and optimised report turnaround times. It allows a quality improvement agenda to be delivered across networks. Next slide. Yes. Yeah, of course. Sorry, I was told I had half an hour. My apologies. So these are the examples of the networks. If we move on to the next slide, please. Cancer alliances also contribute significantly to the diagnostics agenda, and the waiting time standards for cancer and the turnaround times required will be helped by the CDC programme. This describes the rapid diagnostic centres for each cancer alliance and the plans also for targeted lung health check programmes. Next slide, please. I've got some background noise, everybody. I don't know if anyone else has. So I'm just going to show you very briefly what we've done locally in Norfolk and Waveney. So we've gone for a hub and spoke model, the third of the models for the CDC programme. We have 3 acute hospitals. Next slide, please. And you can see those this is Norfolk and Waveney's geography. We have King's Lynn Hospital, the Queen Elizabeth, on the west of the geography, in the centre, the Norfolk and Norwich, and to the east, Great Yarmouth, James Paget Hospital. And you can see the little brighter areas on this map show where the CDCs are designated to be to cover our geography. And I'm going to close there in view of the time constraints. Thank you very much.
Thanks, Erika, for starting off with such a powerful keynote. Apologies that you thought you had half an hour, and thank you for making your slides available. And you've led us nicely into our first panel discussion of the day, recruitment and retention in partnership with Aspirita. Currently, there are 1.3 million people working towards ensuring the best healthcare for patients across the country. And whilst retaining and expanding the workforce is vital for the healthcare system, NHS employers must be able to show value, support, development, and invest in their staff to ensure maximum performance. In April 2020, the NHS created the National Retention Programme, set up as part of the NHS Long Term Plan, to improve staff experience and increase the rate of retention across the country. The NHS must focus on expanding their network to ensure that the NHS is ready for the next generation of nurses, doctors, and essential staff. The NHS will implement an increase in local recruitment, increase the number of apprenticeships on offer, and expand the primary care workforce. In March 2020, professional regulators for health professionals reached out to 70,000 previous employees who had retired since 2017 to encourage a return to practice. More than 15,000 have completed pre-employment checks, 8,755 have been deployed to acute services, and more than 2,000 have been employed across the NHS. It is always nice for me when our discussions are a conversation with you involved. So for the panels, do feel free to use the Q&A function, which you'll find at the right-hand side of your screen. It really helps me if you can say who your question is for. So let's introduce you right away to our first panel guests. We have Francisco Munoz, Business Development Director at Aspirita, Carl Magnus von Behr, doctoral researcher for the Institute for Manufacturing at the Department of Engineering, Paula Baird, Principal Lead, Digitally Enabled Workforce, NHS Education for Scotland, and Faye Lane, Apprenticeship Relationship Manager at Health Education England. So I put my glasses on to check that we've got a full house. And yes, you've all come to life there. We have. Thank you very much for joining us. Francisco, let's start with the basics, really. Is a shortage of staff the single biggest factor impacting patient flow, do you think?
I think when we look at the patient flow, I think there's a couple of things that we need to consider. One is obviously the staff that are deployed to look after those patients, but also is around the processes and how the system works together to be able to cope with the demand. So yes, there is a shortage of staff. And when you look at the figures from the Nuffield Trust or some of these other organizations, in the last year, 32,000 nurses left the NHS. But more importantly, the majority of them were actually under 45. So which is showing that, people are getting tired and people are getting, it's all due to burnout. So one of the key things for me to look at is to improve patient flow. So how do the staff that we have now, do we deploy them better? How do we work with them in different ways that will allow us to obviously provide a better service to the patients, better outcomes, but ensure that the patients go through the hospital as they should be. Just to give you an example, recently last week, I was talking to a CEO of a hospital, and they had a big waiting list on A&E. And the main reason for that was not the capacity of the hospital in terms of needing more beds. It was the ability to actually move people from the hospital into the community. And I think that's where the shortfall of nurses and healthcare assistants comes in. There's not enough people working in the community, allowing more beds to be open, more beds to be managed properly. Some of them require one-to-one services, which is then having an impact on secondary care and an impact on the patient flow. So in a way, yes, there's a shortfall of staff that we know, but it's where that shortfall is and how do we address that to ensure that, the hospitals can move patients through and use better community services like the keynote speaker was saying, Erika, earlier. How do we deliver more in the community to avoid these additional admissions in the hospital?
I shall come back to you for the solution shortly, Francisco, when we've chatted to the other people on our panel. Paula, do feel free to react to what Francisco said there, but I was going to ask you what strategies and delivery plans are in place for workforce development to enable the transformation that's clearly needed.
So in Scotland, we've got our digital health and care strategy, and that is all about the workforce development and digital skills and leadership and about the capabilities across the whole health and care, because that underpins the successful uptake of technology to transform services. But it's also about upskilling leaders to identify where the gaps are, where we could be using technology for the services. And as part of that, we've got the Care in the Digital Age delivery plan to how we will deliver the strategy. And ultimately, it's about digital skills are seen as the core skills for the workforce across health and care. And it's also about defining digital skills. So it's about people are able to use the technology and data that's available to them in their daily role. And we've also got our national workforce strategy in Scotland because our workforce is at the heart of delivering the services that we need to. And with over 400,000 skilled and compassionate people working in many different settings, it's about how we keep them upskilled and retain that talent as well.
Gosh, it sounds like you've been busy where you are, Paula. I'm sure a lot of work's gone into that. Faye, welcome to our discussion. How are apprenticeships being used to broaden diversity and recruitment practices?
Thank you. I guess from a diversity perspective in terms of apprenticeships, we know that they offer an additional supply route, but it's a supply route from probably non-traditional backgrounds, from people who possibly have been excluded from partaking in kind of our traditional entry routes into the NHS. So we know, for example, we get a lot of people who have caring responsibilities, who are career changers, who are coming to us and offering that wealth of prior knowledge and experience, but as I say, are coming from a much more broader background. In terms of recruitment as well, when we look at apprenticeships, we know that predominantly our apprenticeships are recruited internally from internal candidates, and that therefore shortens our recruitment timelines as well. So it allows us to untap talent and potential kind of in a quicker way, in all honesty, as well. So absolutely, we're diversifying that talent pool, and we're also kind of doing it in a slightly quicker way when we're doing it internally anyway.
Carl Magnus, lovely to see you on one of our panels again. Just to explain to us what role digital technologies have played in enabling collaboration and professional development of staff during the pandemic, and perhaps how the positive aspects of that can be carried forward, how we can build on that.
Thank you, Helen, and good morning to everyone. And it's a pleasure to be here again. So I think the role of digital technologies, and I'm looking at it from a estates and facilities point of view, looking at estates and facilities staff. During COVID, you could see there were large challenges relating to different disciplines such as oxygen, fire safety, ventilation, and they all struggled with getting the expertise on site because there were restrictions on who was allowed to go into hospitals. So the kind of main expertise in the estates area are the authorizing engineers, and they were suddenly not allowed to go on site anymore. So the estates staff had to rapidly adopt digital technologies to actually make contact with those experts. And also from a survey that I'm doing at the moment with estate staff, they've said that remote meetings are very important to them. But that only applies for the kind of more managerial levels. So on the technician level, they still struggle getting across their points and their questions in virtual meetings. So they prefer face-to-face meetings where they can literally show their problem to someone. And they still perceive them as more helpful. But I think going forward, the digital technologies have enabled more remote collaboration. But we need to find the right mix of where face-to-face is needed and where we can leverage digital technologies to enable more collaboration among trusts.
That's such an important balance. Paula, just on the digital front, how well, I mean, it sounds like they are massively important given the reports you're writing, but how key are they to the workforce now and in the future? And how important is it that the NHS is focused on that digital arena?
And we did research earlier last year, and it was about how people use technology at home and at work. And the big gap is the technology isn't always there in the work environment. And it's about how we move to automate processes, move away from manual paper processes, and upskill. A lot of that is about developing leaders so that they can identify where the gaps are, they can lead change, and also about executive leadership that at board level, they're making decisions through the lens, a digital lens. So it's about leadership at all levels and how to upskill the gaps to then help and enable transform services at pace and scale.
Francisco, in the absence of a magic wand, to bring more qualified staff to the health services, what changes can the workforce leads make at trust level that you think then will have an impact on patient flow?
I think it's important for workforce leads to start looking more at kind of like total workforce solutions. So a lot of the trusts that I work with, I see that you have your temporary staffing team, you have your permanent recruitment team, you have another team looking after insourcing, another team. So it's all very disjointed. And I think a total workforce approach is required. And on that, obviously collaborative working and collaborative banking, so having a collaborative bank of staff plays an important part. So breaking down the barriers that allows people to work across multiple trusts and multiple locations, including the community. So it's bringing the other providers like local council, as part of the whole picture, but also the use of technologies. I think there's a lot of still probably a bit of reticence to use, all the new digital technologies available. So we've just introduced, for example, digital pre-op assessments, digital mental health. There's digital virtual wards that can be used to manage patients in a different way. So I think it's bringing all of that together under the workforce leads because they understand how the workforce needs to be deployed across all the different aspects rather than keep them in isolation. So I think it's that collaboration across the whole management of the total workforce. That will make a big difference.
Collaboration, all of these conferences come down to that word. It's always our word of the day at the end, collaboration. Faye, question from Carol. Carol says, looking forward, where will you aim to attract apprentices externally?
It's a really interesting debate, in all honesty. We undertook some research a number of years ago, and we are currently refreshing it. But 4 years ago, it showed that 60% of our apprentice intake were internal applicants, and we were only recruiting 40% from external applicants. There is an absolute mind shift that needs to happen, because what predominantly our NHS Foundation trusts have done is they've gone for the quick win, and the quick win is upskilling assistant level staff using apprenticeships, because you can do that in a much shorter time period, and you're addressing some really key workforce shortages in quite a quick way. But what that doesn't do is it doesn't necessarily always attract more diverse talent from external talent pools. So we have to have a bit of a mind shift, and I think we are getting to that point, because we are exhausting that internal talent pool, in all honesty, and we are going to have to start looking externally. I think there are some really key examples across the country where trusts are doing this. For example, Cumbria, Northumberland, Tyne and Wear, as you might be able to tell from my neck of the woods, have started to actually really embrace that they have run out of that internal talent pool and they need to recruit externally. So they're working with local colleges and partners to attract young people in particular from their local economies as well. So I think in terms of how we get there, we are having that mind shift just because we are essentially dredging other talent pools, and we are having to go down other external recruitment techniques. But yes, I think it's more of a cultural shift, and we've gone for the quick wins, and it will absolutely form longer term strategy in our workforce moving forward.
It's hard work, isn't it? You know, when so many sectors need good apprenticeships and apprentices, and there's a skills shortage. So there's a lot of competition out there, I think, to attract good people. Carl Magnus, what role do you think can the new ICS structures play in a more collaborative culture, going back to that word collaboration in the NHS?
I think the new ICS structures, and there's ongoing trials looking at how can we develop strategies for the states and facilities side to clearly communicate and articulate what the ICSs and ICBs are for and what they're not for. I think there's not going to be a one-size-fits-all solution in terms of ICSs providing a solution for collaborative culture, because every region is quite different. And from my study, I can see that trusts of different contexts. So you have a lot of acute trusts, very large acute trusts with multiple sites, with PFI sites, but also community health and mental health trusts. And they prefer to collaborate with trusts of similar context because they will be facing similar issues. So the staff have clearly articulated that for them, it's more useful to have someone in the same kind of position and same kind of responsibility rather than the regional, just the kind of regional trusts around them. Although that is useful as well, and local forums are seen as very useful as well. So again, it needs a mix of both. But ICB planning and ICS planning is not yet seen as a skill that is needed among estate staff. So they don't really know what that's going to involve and how we can make collaborative work among ICSs and within ICSs work. But one thing that the study has shown, which I and I think many assume for a long time, is that the staff don't really feel that feeling of competition among trusts anymore. So they feel like it is one collaborative system. We just need to make it work. They don't feel like the trusts are competing against each other anymore. And also the trusts don't feel like they're so unique that their local context means they shouldn't be talking to their local trusts, but it might be more useful to look abroad. So ICSs can and will play an important role. And it is about articulating the potential benefits and the ways to do that. But cross-regional collaboration is equally important, and getting the right forums together and the right people in the room, I think, will be crucial.
Absolutely. Paula, I'm going to blend one of my questions with a question from Mohammed, if that's okay. I was going to ask you if you've got any examples that you can share of what's underway to retain and develop the workforce. And Mohammed says, where are the incentives? Do we offer time for educational activities, annual leave, team building exercises? Things like that need to be addressed. So that's a bit of a hybrid question for you.
So what we do is we are building like learning networks. So for example, our knowledge, information and data, our specialist workforce, we've created a learning network where we actually engage with the workforce to identify what sort of learning webinars they want us to run. So we're doing a lot of work around R and at the educational level. We're also doing that about, we've recently funded and we're designing a leading digital transformation in health and care master's programme for Scotland. That's funded. Part of the criteria for participants is that they've got to have executive sponsorship. And that's about how when people go through that master's program, that those skills are then used within those organizations and then creating career pathways for people on there. And also, again, it's leadership underpins it all. We've got a digital leadership program for middle level leaders, and that is about giving them the skills to deliver digital projects within their teams and organizations. So it is about investing and giving people time in their roles to upskill and learn.
Yeah, people look, don't they, for career development?
Yes.
To somebody who's an expert in Gen Y the other day, this is a very younger generation in our workforce, and more than pay, they look for career development. And I think that's important when they see that there is a proper path and, you know, they can upskill and have time to learn new things. Elizabeth asks, Francisco, she did ask, and then the questions flashed off. Here we go. There's been a push on international recruitment across the NHS, but given the staffing crisis is a global phenomenon, I can never say that, isn't this just robbing Peter to pay Paul? How do we enable ethical international recruitment? Good question from Elizabeth.
I think that's a very good point. I mean, one of the things we've seen in the NHS lately is these international recruitment initiatives where we're bringing nurses from many different countries like Australia, the Philippines, Kenya, many other places. And I think, to me, I think that's a very good point. There's a shortage of staff across the world. It's not like healthcare is overstaffed and there's nurses everywhere and we're training enough people everywhere. So one of the things we've done as a company in Occasion Group is we developed we've got offices everywhere in most continents. So what we're doing is we developed what we call the Global Pathways program. So what we're trying to do now is offer the opportunity for nurses, medical staff, and even non-medical to be able to travel to other countries at the same time as we're bringing people to the NHS. So there's people, for example, in the NHS that want to go to Australia, whether that could be for a year time, 2 years, or even to settle there. So what we're looking at is with all our partners across the globe, if we are bringing nurses from Australia to the UK, then we ensure that the hospitals that come into work with in the UK actually offer jobs not just to the nurse, but to the family members coming with them. So there could be opportunities for admin and clerical roles, maybe trainee, apprenticeships. So we develop a program that allows the whole family to move together. But at the same time, then we explore who can from the NHS also travel to Australia and cover that gap. So we're developing that program now for many countries, so the US, South Africa, Kenya, Philippines, and Australia, and we'll be looking to expand it. So I think it's about, how do we bring everyone together so we ensure that skills are filled and people are trained and given opportunities to develop into healthcare and join and retain them in healthcare by giving them a good experience.
Absolutely. Faye, how are apprenticeships being used for upskilling and developing new skills? Because there's a role there, isn't there?
There absolutely is. And I think if we were to look, for example, at the nursing associate role in particular, that's a really key and pinnacle example of how we are introducing new roles and diversifying the skill mix as well, because it's been truly transformational in terms of untapping the skill mix within our nurses and allowing them to take on more advanced clinical skills, whilst bridging that gap between those who want to move from healthcare support worker roles into nursing and maybe had previously, for all the reasons I spoke about earlier, not been able to take that leap, maybe go to university because they had all those other responsibilities. So in terms of upskilling, we've got some really key pinnacle apprenticeship qualifications there that are doing that. We know, for example, that apprenticeships don't just address some of those clinical skill gaps as well, but in terms of some of that softer skill development as well. We know when we've surveyed apprentices in the past that they say actually they've built confidence and communication and softer skills. So in terms of personal development and that broader skill mix as well, they're absolutely fundamental in doing a lot of that. Again, we had St Martin's Group, who are a charity who did some research in terms of destinations and outcomes around apprenticeships. And again, they found that in their research, that over 60% of apprentices directly after completing their apprenticeship and into the long term, so 12 months past completion, were still directly using the skills that they had learned during their apprenticeship as well. So we know that we're creating long-term skill mix as well. We're not just equipping people with these short-term skills and they're moving on, but we are directly upskilling and developing new skills as well through apprenticeships.
We only have a minute or so left, so I'm going to try and squeeze in 2 more quick questions. Paula, a question from Romy. Romy says NHS nurses' pay increase, of course, is a major issue. How do we ensure we retain nurses and NHS workers and stop them from moving to private hospitals? I mean, obviously, that's a really important point at the minute, isn't it? And a difficult one to address, I'm sure.
I think it's about listening to them and involving them in service redesign, because they're at the front line. They will have the answers to what we need to do differently. And if you engage people in redesigning services and transformational change, you're also upskilling them. And then it is about how job roles will evolve as part of that. And it's about that, keeping the frontline teams involved and being key part of any transformational change, because job roles will change, skills required will change. And that is about making that, creating that, showing that there's opportunities there for people to learn new skills and career development. But I think it's fundamentally important to listen to the frontline teams, because they'll provide the answers.
Absolutely. Just very briefly, Carl Magnus, because I'm strictly speaking, I'm out of time, but how can the NHS recruit and retain engineers from different backgrounds and career pathways, do you think?
Now I myself again. Can you hear me? Sorry.
Yeah.
So I think there's a huge competitions on the state side as well. And a neat example is the new Hinkley Point C nuclear power plant. So Somerset trusts are really struggling with a lot of engineers going there because I think they need about 14,000 engineers and they'll have a lot higher pay and less working hours. But I think, as Faye said before, and I can see that in my study, the apprenticeship model is working very well. And people think that in-person training and virtual training is very important to them. But they still feel like there's a lack of appropriate training courses available to prepare them for their responsibilities. So a lot of them have multiple services or responsibilities for multiple services, and they have inappropriate staff numbers to cover those. And that means they're not really prepared to actually take full responsibility for their role. So I think what needs to be done, and the NHS is in good progress doing that, is articulating clearly and advertising the benefits of working for the NHS as opposed to the private sector, and providing transparent career and development paths for engineers going into it. So they no matter what career or educational background, know where they can start and where they can go up to if and how they're provided with the development and training to go up to certain roles, and how that whole NHS journey could look like for them. I think that's something that's really coming out.
Final thought from you, Francisco. I just wanted to touch on A&E waiting times. I mean, always in the headlines. Personally experienced dreadful waiting times for my very sick parents at one point. So it's a subject that's very key to my heart. What are the key constraints, do you think, facing A&E departments when targeting their waiting times?
I think there's a couple of elements there. One is obviously the staffing shortage and their ability to see enough patients. But the other one, I think, is also about managing the demand. So clearly, one of the key issues that and I was at one of the best run departments yesterday, A&E departments, with the clinical director walking through. And one of the things we saw is that the access to primary care is actually one of the problems that is leading a lot of people to go to A&E departments. So when we look at the Strep A issue that we had a few weeks ago, they saw a massive influx of parents worried with the kids, which is natural, but most of them didn't need any attention from A&E. And the issue was the inability of those parents to be able to access primary care services or community services that would allow them to, get the comfort and actually get the treatment needed for the children. So I think it's looking at that demand and what can we do in the community to reduce, obviously, attendance. The other one is something I'm doing with this trust is we're looking at a forecasting model. So we can predict what activity for A&E is going to happen over the next 6 weeks, 8 weeks. And that intelligent modeling then will allow us to prepare the rosters for staff in a better way. So we can target staff at the peak times and we can have enough staff at the peak times. So I think it's a combination of both. It's addressing that access point. So how do we provide better community and primary care services? But also then how do we use the staff that we have in a more intelligent way ahead of the peaks that we're going to see on A&E.
Well, that panel has absolutely whizzed by. There's so much more I want to ask you. I do hope you'll all come back. I'd like to invite you all back to another NHE 365. You've been brilliant, and I feel in many ways you've scratched the surface of lots more to talk about. So many, many thanks to our first panelists, to Francisco, Carl, Paula and Faye, for starting us off with engaging conversation on the future of recruitment and retention within the NHS. We're going to take a very short break now, 10 minutes time to absorb what we've learned so far. If you do have chance, do engage with the speed networking functionality and perhaps use what you've learned this morning as an icebreaker. Let's meet back here in 10 minutes time.